Deputy Vice Chancellor Academic, Registrar, University Librarian, Provost of the College of Medicine, Deputy Provost, Dean Faculty of the Clinical Sciences, Deans of other faculties, the postgraduate school and of students, Directors of institutes, Heads of departments, distinguished guests, ladies and gentlemen. The 12th in the series of the University of Ibadan Inaugural Lectures for the 2015-2016 session will be delivered by Professor Onyekwere George Benjamin Nwaorgu of the Department of Otorhinolaryngology on behalf of the Faculty of Clinical Sciences. Born on 23 April 1959 to the family of Mr. Paulinus Nkemjika and late Mrs. Maria Chilen Adama Nwaorgu of Umodagu Ngokala, Imo State, Professor Onyekwere George Benjamin OGB Nwaorgu attended St. John's Primary School in Nwaorgu from 1965 to 1966 and 1970 to 1972. In Nwaorgu High School from 1973 to 1977 and Federal School of Arts and Science, Victoria Land, Lagos from 1977 to 1979. He was offered admission to study medicine in this university in 1980 and obtained the MBBS degree in June 1985. He obtained a postgraduate certificate in epidemiology from the World Health Organization in February 2000. Prior to his working career in this university, Professor Nwaorgu served as a house officer at the then General Hospital, Aba, now Abia State University Teaching Hospital, Aba, between 1985 and 1986, and participated under the National Youth Service Corps scheme as a medical officer at the Tombia Health Center, Delga, local government area of Rivers State, between 1986. He later served as a medical officer in Alvanikoku College of Education Medical Center, Owerri in 1988. He served as senior house officer, registrar, and senior registrar, undergoing specialist training as an Otorhinolaryngologist at the University of Nigeria Teaching Hospital, Enugu, from December 1988 till 1995, when he passed his fellowship examination. Professor Nwaorgu assumed duty as Lecturer 1 in the Department of Otorhinolaryngology with effect from 30th of June 1995 and was appointed as honorary consultant to the University College Hospital in August 1995. He was promoted to the rank of senior lecturer 1st October 1998, reader 1st October 2000, and professor 1st October 2006. He has over 120 publications to his credit, including published abstracts and 112 full-length original articles in peer-reviewed journals. I thought you were going to applaud that. He has successfully supervised 34 postgraduate residence research works, some of whom are now professors scattered all over Nigeria, including one who is presently the Chief Medical Director in a teaching hospital. Within this university, Professor Nwaorgu has served in the following capacities: Coordinator, Department of Otorhinolaryngology between April 1996 and December 1999. Acting Head, Department of Otorhinolaryngology, January 2000 to April 2002 and 2007 till August 2009. Professor and Head, August 2011 and July 2015. He has also served as postgraduate coordinator and member of Faculty of Clinical Sciences Postgraduate Subcommittee, Department of Otorhinolaryngology, representative at the Faculty of Clinical Sciences Committee on Continued Medical Education, Faculty of Clinical Sciences, representative of the College of Medicine Board of Survey, member, College of Medicine Adult Committee on Fundraising, member, Faculty of Clinical Sciences, Appointments and Promotions Committee, member, Business Committee of Senate, and chairman, Board of Health, University of Ibadan, since September 2013. Outside this university, among several others, he was a former professorial consultant in ORL surgeon to the Aminu Kano Teaching Hospital, Kano, between January 2011 and December 2014, as well as a visiting professorial consultant ORL surgeon to University of Abuja Teaching Hospital, Gwagwalada, since January 2013, and serves as an examiner of the Faculty of Otorhinolaryngology Fellowship Examinations of the National Postgraduate Medical College and West African College of Surgeons. He was the chief examiner for the Faculty of ORL West African College of Surgeons Fellowship Examinations from October 2011 to April 2015. Professor Nwaorgu belongs to several professional organizations, including Nigerian Medical Association, American Academy of Otorhinolaryngology, Head and Neck Surgery, American Austrian Foundation, European Academy of Allergy and Clinical Immunology, and Otorhinolaryngological Society of Nigeria. Professor O.G.B. Nwaorgu is a devout Catholic who was ordained a Knight of the Ancient and Noble Order of St. John International, KSJ, in 2003. He is happily married to Adenike Oluwakemi Nwaorgu ní Ajayi Oba, and the marriage is blessed with 3 children. I now call on Professor Nwaorgu to deliver his lecture titled Steady Neck, Stable Head, Unobstructed Throat, the Otorhinolaryngologist at Work.
The Vice Chancellor, sir, Deputy Vice Chancellor, Administration, Deputy Vice Chancellor, Academic, the Registrar and other Principal Officers of the University, Provost of the College of Medicine, Dean of Faculty of Clinical Sciences, Deans of other faculties and postgraduate school, Dean of Students, my Lords Medical, Spiritual, and Temporal, distinguished ladies and gentlemen, it is with great delight, honor, and gratitude to God that I stand before you to deliver today's inaugural lecture on behalf of the Faculty of Clinical Sciences of our great university. This is the second inaugural lecture from the Department of Otorhinolaryngology in 26 years. Professor G.T.A. Jalola, a Dean of Otorhinolaryngology, delivered the first inaugural lecture in 1990. That inaugural lecture was also the first to be delivered in the West African sub-region by a professor of Otorhinolaryngology. The title of his lecture was That All May Hear. Otorhinolaryngology, head and neck surgery, or as it is more often called, ear, nose, and throat surgery, is a branch of medicine involved in the study, diagnosis, and treatment of diseases of the ear, nose, throat, as well as related aspects of the head and neck region. It is worth noting that the Department of Otorhinolaryngology of the University of Ibadan is the oldest in Nigeria. All the previous and present academic staff have contributed significantly to the development of the department. Mr. Vice Chancellor, sir, I crave your indulgence to start my discourse with a rather prophetic story. It came to pass that with the end of the Nigerian Civil War in January 1970, a friend of the family gave a he-goat to my father, who is seated here today. We did observe that the goat was apparently ill. The disease, which I now know as coronavirus cerebralis, results from infestation by the adult tapeworm Tinea morticeps. The coronavirus occurs in sheep and is usually localized in the brain or spinal cord. Other ruminants and man can also be infected. This disease made the goat to stagger and while around, a form of acute meningoencephalitis, which may have been due to the migration of large numbers of immature stages of this parasite. The chronic stages develop as a result of increased destruction of the brain and spinal cord tissue as the coronavirus grows. I almost cried my eyes out as my father resolved to have the goat slaughtered to end this apparent suffering. I remonstrated with my father loudly on this decision of his, but I only later crying and refusal to eat. Fearing not to endanger my health, he rescinded his decision and pushed off the goat to me. I was happy and looked after it to the amazement of everyone. The staggering by the goat resolved over time, only that his movement while walking resembled that of a 911 truck that has lost alignment. Barely 3 months after the initial episode of the he-goat reported above, my younger brother, who is also seated here today, while having his meal, had a fish bone stuck to his throat. All our local attempts at dislodging it failed. As days passed by, the life of my brother became a nightmare. He was really sick, presenting with fever, neck rigidity, draining of saliva, and halitosis. He could not eat. He was obstructed. In search of remedy, my parents got to know that in far away Uyo, there was a hospital where a white man was performing magic in treating such a case. The war just ended, and the family had no money. The goat, which could have been killed months earlier, was sold, and the proceeds used in getting my brother treated at Annual Mission Hospital, Uyo. It was an ENT surgeon that did the magic. My younger brother came back home hale and hearty. He is today a medical laboratory scientist, happily married with 3 fantastic children. Becoming a medical doctor. In my secondary school days, I was very good in the sciences and mathematics. I really intended reading engineering, especially electrical electronic engineering. However, due to recurrent illness in the family, I decided to read medicine. This made me to apply to both Federal School of Arts and Science, Aba and Victoria Land, Lagos, to do physics, chemistry, biology. While that of Aba insisted that I study physics, chemistry, and mathematics, that of Victoria Land gave me my desired option. While in medical school, exactly a week to my second MB exams, I lost my mother. I finished my studies and qualified with an MBBS degree from the College of Medicine, University of Ibadan. During one of my reflection moments, while toying with the idea of specializing in either obstetrics and gynecology or neurosurgery, the voice reminded me of the need to go into the area that saved my younger brother, and thus began my journey into the world of Otorhinolaryngology. My research interest and focus has been mainly in the area of laryngology, head and neck surgery. Over the years, I have addressed the issue of tumors or masses of the head and neck. I have described diagnostic features and rewarding treatment modalities, which are novel modifications of treatment modalities. I have also raised awareness as to the peculiarities of 3 important malignancies in the specialty in our environment, namely nasopharyngeal cancer, sinonasal tumor, and laryngeal cancer. It is worth noting that my brother's case and other patients I encountered during my residency led to my special interest in laryngology, head and neck surgery, and thus the choice of the title of this inaugural lecture, Steady Neck, Stable Head, and Unobstructed Throat, the Otorhinolaryngologist at Work. Nasopharyngeal cancer. Nasopharyngeal cancer is a cancer that starts in the nasopharynx, the upper part of the pharynx, behind the nose and nose, and close to the base of skull. The first report on nasopharyngeal carcinoma in Nigeria was by Ames and Baldwin in 1947. Madison's report of 56 patients in 1968 highlighted the fact that nasopharyngeal cancer was not rare to initial belief. We carried out a review of all histological confirmed cases of nasopharyngeal cancer accumulated in the cancer registry from 1981 to 2000, and noted an annual average increase of 15 nasopharyngeal cases per year, as shown in figure 1. In the 1968 study, nasopharyngeal cancer constituted 1.4% of all cancers in the hospital's cancer registry, while in our 2004 study, it constituted 2% of the total cancers in the same registry. In our study, the male to female ratio was 2.3 to 1, with an overall mean age of 41.1 years. The peak age of incidence for females was in the 20 to 29 years age group. Among the males, this was in the 50 to 59 years age group, with an almost equal number of cases occurring in each of the preceding 3 years, as shown in figure 2. We noted that the ratio of rigor to Schmincke type cancer reversed with increasing age among the females, with the Schmincke type being more common in the early ages, and an equal incidence of histological types in the 5th decade. With respect to the males, both types increased to a peak in the 6th decade, but never really reversed in ratio, as shown in table 1. Rigor and Schmincke histological types constituted 38.6% and 56.1% respectively of the nasopharyngeal cancers. The early peak is associated with the Schmincke type, that is the World Health Organization types 2 and 3 of the nasopharyngeal carcinoma, seen in subpopulations with intermediate incidence. These also have longer remission and survival after treatment. The rigor type of nasopharyngeal cancer, World Health Organization type 1, has been associated with human papillomavirus types 11 and 16, while the SMIC type is more commonly associated with anti-Epstein-Barr virus serologies and EBV DNA in the tumor cells. The peak age of incidence of 20 to 29 years for the females corresponds to the early peak in the age distribution curve of the nasopharyngeal carcinoma patients, and 50 to 59 years of the males to the second peak. We also noted that the suspected etiological agents such as smoking, alcohol and tobacco consumption, eating of salted and gutted smoked fish, and woodwork were not found to be significant factors as noted by some works from Nigeria. There would seem to be an unexplained increased susceptibility of the female sex to early EBV infection. Nasopharyngeal cancer may occur at any age, occurring in endemic proportions in the Chinese population. The disease is thought to be prevalent amongst the Easterners in Nigeria. The adduced reasons for this include the high prevalence of their use of snuff, the geographical distribution which appears to coincide with that of Burkitt's lymphoma, that has its prevalence in the southern parts of the country, where rainfall is maximum, forest widespread, malaria infection, hyper-endemic. Our patients presented with very late disease and diagnosis was hardly in doubt. Occasionally, the patient may present first to the ophthalmologist with diplopia, ophthalmoplegia, or Horner syndrome, and to the neurosurgeon with subtemporal lesions, or even to the neurologist with multiple cranial neuropathies, including velopharyngeal incompetence or dysphagia. The commonest symptom and presentation was neck swelling, as over 65% of the patients presented with cervical node enlargement, example of which is shown in figure 3. In our 12-year retrospective study of 79 nasopharyngeal cancer patients, we documented for the first time in the country and sub-Saharan region 2 essential manifestations, ptosis 15% and Horner syndrome 3%, and thus drawing more attention to ophthalmoneurologic form of presentation as an aid to early diagnosis of nasopharyngeal carcinoma. The treatment of choice for nasopharyngeal cancer is radiotherapy and or chemotherapy. It is worrisome that the increase in the number of cases of nasopharyngeal cancer has not been matched with a commensurate increase in diagnostic and radiotherapeutic centers or facilities for management of the disease. Stage 4 disease with distant metastasis has a 0% 5-year survival. We reported the only case of nasopharyngeal cancer in this environment for now, a male who survived for 8 years following chemoradiation. Primary extranodal non-Hodgkin's lymphoma of the upper aerodigestive tract. Sinonasal cancer is a cancer involving the paranasal sinuses and the nose. Sinonasal cancer is especially challenging in a patient who has been diagnosed with chronic rhinosinusitis with temporary improvement and recurrent symptoms, arising from clinical observations of increasing frequency of sinonasal and nasopharyngeal lymphoma and the paucity of information on primary upper aerodigestive tract lymphomas in our environment. We carried out a 10-year retrospective study highlighting the clinical features, natural history, and response to available therapy of this disease. The mean age of the patients was 42.5 years, with a bimodal frequency of occurrence between age groups 31 to 40 and 51 to 60 years. A total of 16 patients presented with stage 4 disease, all with primary affection of the sinonasal and Wardeyer's ring. We noted the diagnostic problem posed by this malignancy in view of its variable manifestation and late presentation in our environment, as illustrated in figure 4. 38% of the cases were associated with B symptoms, which is usually seen in aggressive disease. Intermediate and high diffuse large cell histological type constituted 61% and 39% respectively, with no diagnosis of low-grade lymphoma. The high-grade tumors were the commonest histological type observed in the sinonasal and nasopharyngeal sites. Majority of the patients had combined therapy, that is chemoradiation, for all the clinical stages, while radiotherapy alone was offered to 32% of those with advanced disease. The disease outcome in our environment is very poor, with 56.6% dead within 1 year of onset of symptoms, and overall mean survival period of 14 months. Our study further confirmed the aggressive nature of the disease in our environment. Inverted papilloma of the nose and paranasal sinuses. This is a relatively rare epithelial neoplasm of the nose and paranasal sinuses, accounting for 0.5 to 4% of the primary tumors of the nose. Following the observation of synchronous and metachronous squamous cell carcinoma, respectively, in 2 of our patients with recurrent inverted papilloma of the nose, we studied retrospectively 15 patients that had histologically confirmed inverted papilloma from 1986 to 2000. 5 of the patients had advanced lesions, of which 4 were bilateral. There were associated synchronous and metachronous squamous cell carcinoma in 2 cases, respectively. We noted bilateral involvement of the nasal cavity in 4 patients. 2 patients with only inverted papilloma and 1 patient with metachronous malignancy, who had no evidence of septal perforation or erosion, while the 4th, with a synchronous malignancy, had evidence of septal perforation. Though inverted papilloma is a relatively rare neoplasm, its features of aggressiveness, recurrence, and association with malignancy, as shown in our study, is worthy of note. The lesion is mostly unilateral, but in our study, 3 patients had bilateral involvement without any evidence of septal erosion or perforation, in contrast to direct spread through the nasal septum. Direct spread through the nasal septum was noted only in the patient with synchronous carcinoma. Based on our findings, we made case for radical surgery, that is medium isolectomy, for its management in our environment, while stressing the need to intimate any patient with inverted papilloma to adhere to regular follow-up post-surgery. Carcinoma of the larynx. This important malignant epithelial neoplasm is the 3rd most common carcinoma of the head and neck region observed in the ORL clinic of the University College Hospital, Ibadan. Though the real incidence in our center has not been established, between 1986 and 1995, laryngeal carcinoma constituted 28.6% of the total ORL carcinomas recorded in the Ibadan Cancer Registry. We evaluated 72 patients with histological confirmed cancer of the larynx, comprising 65 males and 7 females, with a male-to-female ratio of 9:1. The patients had an overall mean age of 55.8 years, while the peak age was in the 5th decade of life. The vocal cord considered the commonest anatomic site in about 29% of cases. Histologic analysis revealed that 94 patients had squamous cell carcinoma of the larynx. Majority of our patients presented within 1 year of the onset of their symptoms, reaching a peak of about 84.7% at 2 years. Majority of the patients had advanced disease, that's stages 3 and 4. Hoarseness, difficulty with breathing, were the most common symptoms, and 64 patients presented in acute upper airway obstruction, necessitating emergency tracheostomy. It is worth noting that in our environment, presenting late to specialists in the hospital could be attributed to all or any of the following: non-specific symptoms of the laryngeal lesions at the early stage, religious and social cultural beliefs and practices of the people, poverty, illiteracy, and initial self-medication. We reiterated the need for improved awareness of the general populace through social campaign and general health programs similar to those conducted for lung cancer. This will enable early referral of patients presenting with signs and symptoms of airway obstruction to the ORL specialist for appropriate evaluation and treatment. Total laryngectomy is our preferred treatment option for advanced cancer of the larynx. Total laryngectomy means removal of the whole larynx, and cases of failed radiotherapy. However, many of these patients opt for radiotherapy or chemotherapy in spite of adequate counseling for fear of losing the voice box, and thus unable to speak after surgery. Advanced disease and previous irradiation of the neck cause tissue fibrosis, reduce blood supply, and hinder wound healing, and thus contributed to the development of pharyngocutaneous fistula in some of our patients. Faced with this challenge, we use the pectoralis major musculocutaneous pedicle flap to carry out a one-stage pharyngoesophageal repair of pharyngocutaneous fistula with good result, as shown in figure 5. Our initial experience with the first case was highlighted in the population entitled One-Stage Pharyngoesophageal Repair of the Pharyngocutaneous Fistula and Esophageal Stenosis using a pectoralis major musculocutaneous pedicle flap. This, to our knowledge, was the first of such a successful restoration of pharyngoesophageal lumen, following total laryngectomy complicated by pharyngocutaneous fistula in Nigeria and the South region. Success stories of other cases of pharyngocutaneous fistula managed with this procedure have followed this initial case in Nigeria. Stomal recurrence. Tumor recurrence at the tracheostome is a major complication experienced post-surgery of advanced cancer of the larynx, many a time it has grave prognosis. We retrospectively studied 18 patients that had total laryngectomy for histologically confirmed carcinoma of the larynx of a 12-year period for stomal recurrence and possible predisposing factors. All the patients were hoarse at presentation, with 15 in severe stridor, signaling significant obstructive laryngeal airway. Pre-laryngectomy, 14 patients and 4 patients had emergency and elective tracheostomy procedure respectively. Post-operatively, 12 patients had only radical radiotherapy. 4 had chemoradiation, while 2 had pre-operative and additional post-operative radiotherapy. The mean duration between the pre-operative tracheostomy and total laryngectomy was 62.2 days, while the mean duration between total laryngectomy and development of stomal recurrence was 7.8 months. 10 patients 10 patients died. We observed that the mean duration from onset of symptoms to date for those with stomal recurrence was 28.3 months, and that only 4 patients without recurrence were still alive as at the time of our report. Based on the foregoing, we concluded that advanced stage of disease, involvement of all the subsites of the larynx, and the presence of preoperative tracheostomy was the likely risk factors that could be associated with stomal recurrence in our environment. Emergency total laryngectomy has not been possible in our environment, as people in this environment reject losing their voice at the initial stage of informing them of the type of lesion and possible outcomes. Flowing from our findings, we advise adequate counseling of the prospective laryngectomy to be carried out in the presence of 1 or 2 previous laryngectomies. As surgery, dissection of paratracheal, pretracheal, and retrosternal nodes, and complete excision of previous tracheostomy tract are carried out. This practice thus has reduced the incidence of this complication in our center. Vice Chancellor, sir. Lead presentation is still a problem, although there is an improvement in the level of awareness on carcinoma of the larynx with a consistent rise in the number of patients presenting to us. A challenge which still remains incompletely solved is voice restoration post-laryngectomy. Post-laryngectomy speech rehabilitation in our patients has been by esophageal speech mainly, except in 2 patients who are using electrolarynx, and more recently, tracheoesophageal voice prosthesis in a patient. Head and neck cancers. Following a retrospective study of cancer of the larynx, we decided to look at the prevalence and pattern of head and neck cancers, especially with respect to the retroviral status of our patients from 1996 to 2005. A total of 521 head and neck cancers were seen within the study period, with a peak in the 2004 to 2005, as shown in figure 6. Head and neck cancers were most common in the 6th decade of life in this study, as also illustrated in figure 7. 10 patients were HIV seropositive, giving a prevalence of 1.9. Their ages range from 17 to 64 years, with 70% being within the age range 17 to 45 years. Laryngeal cancers were the most common head and neck cancers seen in this study, as shown in table 2. There were 11 cases of malignant salivary gland cancers, all parotid, with 4 of them being HIV/AIDS seropositive. High rates of salivary gland diseases, not necessarily tumors, were observed by Massadupoch et al. In 2004, Morgan Oshowole in 2005, and Bakari Ahmad and Inaugural in 2005. Massadupoch et al. In 2005 attributed this to a probable increase in HIV concentration in saliva. The HIV seropositivity of 1.9% in our study was high in comparison with the cohort report of 1.6 in 10,000 cases by Poes et al. This may not be unconnected with the high prevalence of HIV in sub-Saharan Africa. The United Nations Program on HIV/AIDS, UNAIDS 2005 report described Nigeria as one of those countries with the most rapidly increasing numbers of cases of HIV/AIDS. The period 2004 to 2006 recorded more cases of HIV seropositivity, whereas none was recorded in 1997 to 2000. This picture coincided with the period with the highest prevalence of head and neck cancers. Thus, we infer that there may be a weak relationship between HIV/AIDS seropositivity and malignant head and neck neoplasm, as also postulated by Powers et al. There is thus a need for further research into the factors responsible for high salivary gland involvement in HIV seropositive patients, especially in the tropics. However, we are unable to establish whether primary head and neck cancers occurred more frequently in HIV/AIDS patients than in the general population, although an inference could be drawn as it was with the study of Powers et al. In a research study on head and neck cancers, we noted decreased serum level of micronutrients, that is vitamin A and zinc, in our patients. It was a case-control study of 65 consecutive patients with historical diagnosis of head and neck squamous cell cancer and 65 healthy volunteers, similar in age, sex, and socioeconomic status. 55 patients presented with advanced form of the disease. The mean body mass index of cases and control were 22.7 and 23.1, respectively. The mean serum zinc level of the controls was 113.6 micrograms per deciliter and was higher than the cases, 89.8 microgram per deciliter. The mean serum vitamin A retinol level of the controls was 77.7 and was significantly higher than the cases, which with their own value at 61.3 micrograms per deciliter. Although no abnormality of serum zinc and retinol was found in both groups, there is a trend of lower levels of these nutrients in the patients than the healthy individuals. Thus, we concluded that head and neck squamous cell carcinoma patients are more malnourished than the healthy population. Mr. Vice Chancellor, sir, this is an ORL, Otorhinolaryngology presentation, and I would therefore crave your indulgence to service my throat. Sorry, please. Thank you, Mr. Vice Chancellor. Now, upper airway obstruction. The upper airway extends from the anterior nares to the stratothoracic trachea, as illustrated in figure 11. Stridor and dyspnea are symptoms indicative of respiratory tract obstruction, which may be present in both benign and life-threatening disorders involving the upper airway. We studied 80 consecutive patients who presented to us with upper airway obstruction to determine the various etiologies of this clinical state and their relative incidences over a 10-year period. The age range was 6 months to 70 years. The most common site of obstruction was the larynx. The study revealed a spectrum of causes of upper airway obstruction in our environment. The acquired causes of upper airway obstruction were 79, while congenital was just 1, as illustrated in table 5. In children, the most common causes were recurrent respiratory papillomatosis, laryngeal foreign body, and laryngeal foreign body, while in the adult, laryngeal carcinoma and laryngeal injuries were the most common. In Mukherjee's 1977 study of 49 cases of upper respiratory tract obstruction, recurrent respiratory papillomatosis considered the highest cause, followed by diphtheria. In Okafor's 1981 analysis of 82 cases of airway obstruction, laryngeal foreign bodies considered the highest, followed by recurrent respiratory papillomatosis. The observed increase in cases of direct laryngeal injuries and laryngeal carcinoma may be due to lifestyle changes and increase in physical sports, automobile accidents, and smoking in our study. It is worth noting that 56 of the patients had tracheostomy to relieve the airway obstruction before the definitive treatment. Thus, we advise support of community awareness and health education programs tailored at encouraging early presentation, prompt referral to experts, and thus improve the outcome of treated cases. Deriving from the above study, my colleagues and I decided to review the indications for tracheostomies and see if there is any change in this trend at the University College Hospital Ibadan over a 10-year period. Tracheostomy is an important life-saving procedure in the management of the obstructed airway. Figure 12 illustrates some stages of tracheostomy. There were 218 tracheostomies, which constituted 13% of the total ORL surgical procedures during the period. We noted a progressive increase in the number of tracheostomies performed. Upper airway obstruction was the indication in 61.4% of cases across all age groups, corroborating the findings of previous works. Tumors accounted for 58.2% of upper airway obstruction, followed by trauma in 22% of cases. We reaffirmed the rational use of tracheostomy in infective cases of upper airway obstruction, bearing in mind the improved conservative methods of management using humidified oxygen, anti-inflammatory medications, antimicrobials, and endotracheal intubation, especially in cases of severe stridor. As important as tracheostomy is, it also has its associated complication, as highlighted in our study titled Complications of Classical Tracheostomy and Management. 179 tracheostomies were performed in 168 patients, out of which 69 had complications, as shown in tables 6 and 7. Complications occurred in 54% emergency cases and 26% elective cases, a difference which was statistically significant. The overall mortality rate was 2.2%. The complication rate compares with that of Okafor, publication of 1981. We recommended a standard approach towards tracheostomy and its care in hospital, especially in emergency situations, and regular follow-up for those on long-term or permanent tracheostomy, having thoroughly instructed them on home care of their tracheostomies. Recurring respiratory papillomatosis. This is the most common benign neoplasm of the larynx, known to result in upper airway obstruction, and which has most often been misdiagnosed in our environment as lower airway disease in children. It is etiologically associated with human papillomavirus, subtypes 6 and 11. Nwaorgu and Onokoya in 2004 reported the first flurry case of recurrent respiratory papillomatosis of the pharynx in an 18-month-old female child, which mimicked erythropharyngeal abscess in the subregion. Following this, I, alongside my colleagues, reviewed 43 cases of histologically confirmed cases of recurrent respiratory papillomatosis managed at the UCH Ibadan from 1988 to 2002, with a view to determining the clinical features and cause of the disease. Majority of the patients were aged between 1 to 10 years, with the age group 6 to 10 having the highest prevalence of 39.5%. In the areas recording the second peak, it has been noted that the mode of transmission is via sexual contact or indirect contact with anogenital lesions with a slight male preponderance. All the patients were hoarse at presentation, with 70% of them dyspneic and had to have emergency tracheostomy at presentation. Our main style of treatment was microlaryngoscopy and excision of the papillomata aimed at disease eradication and preservation of serviceable voice. Many authors believe that the incidence of tracheostomy is more in younger children with aggressive disease. This select group tends to have frequent recurrences following excision. Our experience is different in respect of recurrences, as there was no recurrence in 53.5% of the patients after the initial surgery, in spite of the fact that majority were obstructed at presentation, and the highest incidence of 5 occurrences over the 10-year period were only in 2 patients. With regard to the clinical diagnosis of the referring physician, only in 15 cases was there an accurate diagnosis, as shown in Table 8, while noting that majority of the patients were of the 4th order of birth in their respective families, as illustrated in Table 9. Our finding is a variance with the belief that recurrent respiratory papillomatosis is more prevalent among firstborns vaginally delivered by teenage mothers with genital wart. It is also known that apart from vertical transmission, in which there is a chance of 1 in 400 transmission of human papillomavirus, there can be hematogenous spread and ascending placenta inoculation. This may explain the finding of the disease more prevalent in the 4th order of birth in our study, while supporting argument against selective cesarean section in women with vaginal warts. Bearing in mind complications associated with tracheostomy, loss of serviceable voice resulting from delayed presentation, and repeated excision of papillomata, we advise a high index of suspicion and prompt referral in any patient with a progressive voice change exceeding 3 weeks unresponsive to standard medical therapy. Hoarseness. Voice is produced in the larynx by vibration of the vocal cords in an expiratory blast of air. For the production of pure and pleasing tones, there must be an accurate balance between the adductors and abductor muscles of the larynx. Maintenance of an even respiratory air pressure and the margins of the vocal cords must be smooth and unimpeded in their separation and recoil. Deviation from this leads to hoarseness. Hoarseness and stridor, that's obstructed breathing, are the 2 major symptoms of laryngeal disease. Considering the morbidity and mortality inherent with some lesions that present with associated persistent hoarseness and scanty otorhinolaryngology services available in Nigeria, my colleagues and I evaluated 124 hoarse adult Nigerian patients over an 8-year period. Chronic non-specific laryngitis, including vocal cord nodules, was the most common cause of hoarseness, as indicated in Table 10. This is in agreement with the previous works in Nigeria. The prevalence was more among professional voice users, traders, preachers, and teachers. A sample of singer's nodule is shown in figure 13. Mr. Vice Chancellor, sir, I can assure you that this, contrary to what Professor Oladoku may be thinking, is in my own area of jurisdiction. Well, I don't know what Professor Hamzat may be thinking, but I can assure you that everybody here has this very structure. That's the larynx. From our study, the pathologies associated with hoarseness are varied, and persistence for more than 3 weeks should prompt early referral to specialists for detailed otorhinolaryngological evaluation. In a similar study with my colleagues on pathologies associated with hoarseness in 56 children seen at the ORL clinics of 2 tertiary health institutions in Nigeria, the most common pathology identified was recurrent respiratory papillomatosis, followed by acute laryngeal infections, as shown in Table 11. It is worth noting that the age group 4 to 7 had the highest prevalence of recurrent respiratory papillomatosis. The patients had a mean duration of 17.4 months before presentation, with 62% of the patients dyspneic at presentation, necessitating tracheostomy, as shown in Table 12. The acute infections, namely measles, epiglottitis, croup, diphtheria, and retropharyngeal abscess, presented relatively early, and all but the diphtheria cases responded to therapy. Gonococcal pharyngitis. Pharyngitis is the inflammation of the pharynx, commonly referred to as sore throat, and most times is of viral etiology. In a collateral study, we investigated the possibility of isolating Neisseria gonorrhea from the throat swabs of 102 female patients seen at the ORL clinic, 85% of whom complained of sore throat, and 341 patients from the special treatment clinic. 98 of the 341 patients screened had positive genital Neisseria gonorrhea culture, while 11 had gonococcal pharyngeal infection. There was none isolated from the throat swab of the 102 ORL clinic patients. However, 16 had streptococcal pyogens isolated. 24 females from the STC admitted to the practice of fellatio, which is orogenital sex, while 9 of the 11 patients with pharyngeal gonococcal infection had a history of fellatio. We concluded that pharyngeal infection was significantly associated with gonococcal genital infection, while the practice of fellatio was therefore associated with pharyngeal gonococcal infection. Thus, whoever practices orogenital sex and has genital gonococcal infection is at risk of developing pharyngeal gonococcal infection. And I say, again, Mr. Vice Chancellor, that again, the person might be paving a way for the development of oropharyngeal cancer. The Vice Chancellor, sir, my submissions above have highlighted human papillomavirus, Epstein-Barr virus, HIV, exposure to polycyclic hydrocarbons, and some dietary deficiencies as risk factors in the development of head and neck neoplasms. We know that the prevalence of human papillomavirus in relation to head and neck neoplasms is on the increase. The infection is acquired mostly through birth canal or orogenital sex with someone who has the infection in our environment. Engaging in such sexual practice is culturally and religiously unacceptable. Hence, in our study, participants were too shy to volunteer the information. Also, religious and social-cultural beliefs and practices of the people, in addition to the non-specific symptoms of the lesions at an early stage, contributed to delay in the presentation at the health facilities for specialist evaluation. Inadequate or non-availability of diagnostic equipment, non-functioning of treatment facilities conspire to worsen the prognosis in these already advanced cases. Mr. Vice Chancellor, sir, as a laryngologist, head and neck surgeon, I wish to dwell a bit on a disease entity which has made most of the patients or the parents of the afflicted child night watchmen and emergency prayer warriors, and that's adenoidal disease. The adenoid is an aggregation of lymphoid tissue, pyramidal shaped, with its base on the posterior nasopharyngeal wall, and its apex pointed toward the nasal septum, which attains its maximum size between the ages of 3 and 7 years. A lateral soft tissue X-ray of the postnasal space is a reliable way of assessing adenoidal size, as shown in figure 14. This assesses the absolute size of the adenoids and its relationship to the nasopharyngeal two of my trainees, Dr. A. Adioshu and A.O.A. Ogunleye, just passed their Part 2 fellowship examinations. He gave them temporary appointment the next day. And so we became 3 academic staff in the department. Together we were able to train more fellows, 2 of whom, Dr. now Professor Lasisi, and Dr. Onokoya, my great acting head of department, joined the academic staff in December 2000 and January 2001 respectively. Unfortunately, on 29th October 2006, we lost Dr. Ogunleye in an air crash. The department now has 7 academic staff. Mr. Vice Chancellor, sir, it is with humility and air of fulfillment I inform you and this wonderful audience that with my colleagues, we have trained many otorhinolaryngologists for Nigeria and the sub-region. Many of them are here today. Among our products are Professor B.M. Ahmad, University of Maiduguri Teaching Hospital, Professor K.R. Isse, whom I have cited somewhere here, immediate past head, Department of ORL, Udit. Professor A.D. Dumade, I have also cited him. He's here. ORL Department, UITH Ilori. Professor T.S. Ibekwe, I have also cited him. Head Department of ORL, UITH Abuja. Dr. Aminu Bakare, Associate Professor and Medical Director, National Ear Care Center, Kaduna. Dr. A.S. Adoga and Dr. A.A. Adoga, both brothers, who are now readers at JUT, JOS. And Dr. Elu Onotai, I have also cited him here today, from Port Harcourt. Today, Mr. Vice Chancellor, I will say that I'm a fulfilled man and will, however, keep on doing my best for the advancement of the specialty to keep up with world standard and best practices. Recommendation. Mr. Vice Chancellor, the treatment modalities for head and neck cancers include surgery, chemotherapy, and radiotherapy. The successful management depends on accurate diagnosis, tumor stage, and selection of appropriate treatment modality, and close post-operative follow-up. Thus, targeted and well-coordinated health education and awareness program for all rare diseases and their prevention at community level through various media and even religious organizations should be pursued through appropriate and relevant agencies. Inclusion of therapy for head and neck cancers in the existing national health insurance scheme in Nigeria will likely encourage early presentation to the ORS specialists, while also reducing the default from treatment. It is desirable that functional world-class centers for the management of head and neck cancers are established in the 6 geopolitical zones of the country, and programs aimed at creating awareness and encouraging immunization against human papillomavirus and other infective agents will go a long way in prevention of the infection and other agents that may result in neck infections and abscess. Acknowledgement. In a presentation as this, the likelihood of missing out some people unintentionally exists. Let me assure us that there are no intended and not meant to slight anyone. My special tribute and appreciation go to 2 wonderful beings that I had the privilege of being taught by at St. John's Primary School in Maryland, Imo State. And there are Mrs. Teresa Nwaorgu, now late, Mr. Akodike, also late. I thank all my teachers, and especially Professor G.T.A. Jalola, who was instrumental to my taking up appointment as a lecturer in the University of Ibadan. Mr. Vice Chancellor, sir, I'm indebted to Professor B.C.A. Zanole, Ezugomuta. Mr. Vice Chancellor, sir, that's my trainer, my leading trainer at the UNTH, Enugu. He actually got me appointment at Newi, but I declined and ran away. Sir, I apologize here now. I thank all my colleagues in the Department of ORL. My acting head of department, Dr. P.A. Onokoya, Dr. A. Adioshu, the gentleman, Professor O.A. Lasisi, Dr. A.A. Adeyemo, Dr. A.J. Fasula, very, very energetic. Thank you. Dr. A. Daniel and Dr. S.A. Omukende, as well as the wonderful residents that are presently in or have passed through the department for their support. Mr. Vice Chancellor, sir, I'm sure if you look closely in the audience, you may be able to sieve out this group of people that I've just mentioned. I'm also grateful to a doyen of otorhinolaryngology, Professor F.O. Ogisi, who is here with us today in person, all the way from UBTH. Sir, nobody is going to kidnap you here. We don't kidnap in this place. Professor Dr. Sir G.W. Broby of Ghana, Professor C.C. Nwaorgu, Professor O. Omotade, Professor K.T. Robbins, Director and Chair, Simon Cooper Cancer Institute, Southern Illinois University School of Medicine, and St. John's Hospital, Springfield, Illinois. Professor Michael G. Stewart, Chairman of the Department of Otorhinolaryngology, Well Medical College, Cornell University, and Otorhinolaryngologist in Chief at New York Presbyterian Hospital, Cornell Medical Center, and Professor Eric Bloom for their contributions to my specialist growth. I also thank Dr. Olesho Biko, Dr. J. Olabisi, and I've cited him here, and His Royal Majesty, KBSC, Dr. Florencio Makonju, Mr. Vice Chancellor, sir. These three people, while I was the only one in the department, they were associate lecturers. And when it appeared as if some people were going to deal with me, the three intervened. I'm grateful to them. Dr. Olaleye Aji provided me with shelter during my first 6 months as a lecturer in the University of Ibadan, for which I remain grateful. Alhaji Chief Latif Oyelade, Otumba Kunle Kalejaye, all present. They are my benefactors. I think I have to reveal this thing here now, sir. That when I came and I was jumping into Molue and coming down, Chief Oyelade saw me and said, no, this cannot be a consultant in the University of Ibadan. So he bought me a Honda Civic. The ORA family today, they know me with a particular head lamp. There are other several head lamps that we use in ORL today. And I know that Professor M.T. Shokumbi is in this group. He may recall that at a stage we had pager. That pager saved the department from being non-accredited in the early 80s. I mean, the early 90s. And the person that supplied those pagers free of charge and the headlamps is Otumba Kunle Kalejaye. They've also helped to sponsor me to various conferences and immensely contributed to my work and stay in the department. I thank them most sincerely and pray for God's continued blessings on you and your families. I appreciate posthumously Professor T.F. Sholanke. Mr. Vice Chancellor, sir, he took me out of the shores of this country on my first international presentation conference and guided me very well. I'm indeed grateful to all professors in surgery department for their mentorship and encouragement. Professor O.O.A. Ajayi, I cited him here today. He willingly submitted himself. We know that he is a great surgeon of international repute. He could have gone to America, Britain, or anywhere of his choice to have surgery performed. But he submitted himself to me, and I did work on him. Sir, I'm happy that your face is still handsome. Your nose is intact. I thank him for such a great confidence reposed on me, and also God, that I never let him down. My silent admirers in the College of Medicine are too numerous to mention. I say thank you all. I shall forever remain grateful to the various successive administrations of the College of Medicine, University of Ibadan, especially Professor O. Ejomwede, Professor M.T. Shokumbi, Professor A.O. Nwaorgu, Professor O.O. Akinyika, Professor B.R. Salako, Professor O.M. Oluwatosin, the gentleman, and my Dean, Professor A.O. Malomo, very, very energetic. They contributed great to the development of my department. I forever remain grateful To my academic fathers in the University of Ibadan, Professor O.O. Ajayi, Professor I.F. Adewale, and Professor A.O. Falashe, I acknowledge you and Professor O.O. Akinka for your unquantifiable piece of advice and mentoring. My gratitude also goes to the management of University College Hospital, Ibadan, ably led by the great orator, Professor Temitokwe Alonge. I really appreciate the friendship of the University orator, gentleman Professor T.K. Hamzat, Professor Shina Oladoku, Professor A.R.A. Alada, Professor Y. Raji, Professor Feintola Professor O.S. by the grace of God, O.S. Arulogu, Professor F.E. Ologe, Dr. Gani Adenero, the great one, and Dr. A. Imogu. Thank you so much for your comradeship. I also acknowledge my colleagues at the departments of ORA, University of Abuja Teaching Hospital, Gobolada, and Minukano Teaching Hospital, Kano. I remain grateful to all my research collaborators, especially Professor J.O. Gumbi and Professor R.A. Bakari, Professor E.U. Akang of late memory, and Dr. E.A. Skolo. I acknowledge all my patients here present. I have here my prized patients, Deaconess Deborah Akogu, Emmanuel Mr. Emmanuel, and then Miss Tina Adefulare. I appreciate the counseling and prayers of my spiritual directors, Reverend Father Piero, late Reverend Father Omolade, Reverend Father Akombi, His Lordship Bishop Odoto Imbo, Reverend Sister Stella Maris, and the prayer warriors of Pro Laborate Day. My special gratitude goes to my brother and sister knights who are here in their numbers of St. John International Commandery 573 and Lux 474, Church of the Ascension, Bodija. I'm grateful to Daddy Adwayne, my former landlord, for being such a fine, dependable gentleman. I also recognize the contributions of my mother-in-law and father-in-law, the King Samson and Rachel Ajoba, now late, and the entire Ajoba family, for allowing their daughter to escape to Imo State with me. I appreciate the support and presence of members of my town union, the Ngobala Welfare Association, and to my brothers and sisters in Otumuna in Ibadan. I remain grateful. I thank my father, who is here today. In a few weeks' time, he will be turning 90 years. And Maria Selling Wong for giving me the opportunity of a higher education. I thank my brothers who are all here, all of them, Romanus Wong, the oil minister, Martin, Chile, Mary Colette, Mary Joan, and Henry. You are all wonderful people. Thank you for their love and understanding. My brother-in-laws are here, Chief Eze, Emeka Chukwueze, Dr. I. Ago, and Mr. Collins Aranya are all appreciated. My wonderful and ever supportive cousin, Engineer Kenneth Wong, is highly appreciated. I thank my wife for her love and support and giving me the conducive environment to pursue my academic activities and work. I thank God for not only giving me academic children, but also my own biological children. Ayomide Uchenna, Olufemi Victoria, and Chimdemma Emmanuel Wong. I thank them for making the house warm and lively. May all honor, glory, and adoration be to the Most High God. Amen. I thank you, wonderful audience, for your patience and attention. Thank you.